and the video series of neurology medicine. Today I will discuss meningitis. So what is basically meningitis? Meningitis is the infection or inflammation of meninges, right? It is the infection or inflammation of meninges. Now what is meninges? Meninges are the layer which surround the brain and spinal cord, right? Let's say if this is a brain, so just adherent to the brain there is pyometer, then arachnoid matter, and then dura mater, which is adherent to the skull. The meningitis, it is the infection of pyometer, right? It's important. It is the infection of pyometer. It is somehow different with encephalitis. Encephalitis is the infection of brain substance. Usually the patient is presented with fever and confusion. But in case of meningitis, the patient is presented with the fever, headache, and neck stiffness or neck rigidity. Now, fever, headache, and neck stiffness, these are considered as a classical triad for the meningitis. It is the classical triad for meningitis. While it is being reported that in 69% patients of meningitis, they can present with altered mental status. Altered mental status, and if you look upon the GCS value, the GCS comes less than 14, and it is most commonly seen in 69% patient with meningitis. So along with the fever, headache, neck stiffness, there will be altered mental status. There might be some features as well. Usually the patient can give you the history of photosensitivity. There might be hyponatremia, and in 5% cases you can see seizures, and you can see the skin rashes, mainly when meningitis is caused by Neisseria meningitidis. Now let's talk about the signs of meningeal irritation. Important signs of meningitis. The first is that is called as nuchal stiffness or nuchal rigidity, and Kernig sign, and the other is Brudzinski sign. The most common sign in meningitis is neck stiffness. Now what happens in neck rigidity or neck stiffness? So in neck stiffness, the patient lying in a supine position, and you will have to flex the patient neck in such a way that the patient chin should touch the patient's sternum, right? So in case of meningitis, when you are trying to do the flexion at the neck area, so there will be extreme rigidity and neck stiffness in the patient, so that you could not move the neck up to the halfway, right? It is the nuchal stiffness. Well, if I say what is Kernig sign? Now in Kernig sign, now you will have to do the flexion at the hip joint, and you will see that there is flexion occur at the thigh area with the 90 degree. So the leg is already, it get flexed at the 90 degree. Then slowly straighten the patient leg, and the extreme pain is offered by patients mainly in the back area, or due to severe pain, patient can flex the other knee joint as well, right? So that is Kernig sign. Now what is Brudzinski sign? In Brudzinski sign, patient is in a supine position and the leg is straightened. So the meninges or spinal cord, it gets stretched. So because of that, the patient feel pain. So in order to relieve from pain, the patient will flex the knee joint. Now let's talk about the transmission of infection to the brain. So the most common route for the infection, that is hematogenous route. So hematogenous route, it is the most common route for the meningitis. Also the trauma can lead to meningitis. If there is local infection from otitis media or from dental infection, that can lead to meningitis. The causes of meningitis. So The most common cause of meningitis is Streptococcus pneumoniae. It is very important. The Streptococcus pneumoniae, it is the most common cause of meningitis, especially in less than 20-year-old patient. This Streptococcus pneumoniae, it can cause meningitis, and it is associated with the Austrian syndrome, right? It is associated with Austrian syndrome, and it is also called as Osler triad. Now in Osler triad, there is meningitis, endocarditis, and pneumonia. Streptococcus pneumoniae is associated with this special triad that is called as Osler triad. Osler triad. It is also called as Austrian syndrome. Austrian syndrome, and it consists of meningitis, endocarditis, and pneumonia. Now, what are the other causes? Neisseria meningitidis. Now, Neisseria meningitidis, it can cause meningitis, especially in adolescent, and it is mostly associated with the skin rashes. Like if there is meningitis because of Neisseria meningitidis, so you can see the skin rashes, petechiae, and purpura as well. Now the other causes are Listeria monocytogenes can cause meningitis, especially in immunocompromised patient. Also, the Haemophilus influenzae can cause meningitis, but the most common age group is from 2 months to 2 years. Right? Now, other causes include Cryptococcus neoformans. Cryptococcus neoformans, it causes infection mostly in HIV patient. It causes infection in HIV patient when the CD4 count it is less than 100. And viral can cause meningitis, and when viral cause meningitis, that is called as aseptic meningitis. Now, what are the investigation options? The best initial test for the meningitis, that is CSF examination. CSF examination, it is the best initial test, but there are certain exceptions. Right? CSF examination is the best initial test, but in some cases, the CT scan, it is considered as the best initial test. It is important. Commonly, the best initial test is CSF, but in certain conditions, the best initial test is CT scan done before the CSF examination. And what are those conditions? Papillary edema, when there is increased intracranial pressure, seizure, focal neurological deficit, and coma. It's important. The CT scan is done in papillary edema, seizure, focal neurological deficits, and the coma. And what condition we can do LP, and what are the conditions that we should not do LP? So what are the conditions that we should not do lumbar puncture? And there are some conditions in which we have to do lumbar puncture. Now if I say lumbar puncture should not be done, so for that you have to recall the mnemonic, that is phase. So in the phase, you should not do lumbar puncture. It is very important. Now, if there is focal neurological deficits, so you should not do lumbar puncture, right? Now, if there is altered mental status where GCS level is less than 14, you should not do lumbar puncture. It's important. Now, if there is increased intracranial pressure, like instead of papillary edema, you cannot do lumbar puncture, right? Now, if there is localized lesion and if there is seizure, so you should not do lumbar puncture. It is very important that what are the conditions where the LP is not recommended. For that is focal neurological deficits, altered mental status, papillary edema, localized lesion, and seizure. So why we are not doing the LP in these certain conditions? That is because of space occupying lesion. In this condition there might be mass in the brain, so you should not do the lumbar puncture. So if you do the lumbar puncture, there is highly risk of herniation of brain. So in this condition, you should do the you should give antibiotics and do CT scan to rule out the mass. Now, in the lumbar puncture, you should send the cell count and you should send the culture. Now, if you see, if there is two possibilities, if there is a polymorphonuclear predominance, or if there is lymphocytes predominant. So, if there is polymorphoneutrophil is predominant, so that will be called as bacterial meningitis. That will be called as bacterial meningitis. But if in the culture, if there is lymphocytes predominant, there are three possibilities. It might be tubercular meningitis, right? It might be viral meningitis, and it might be fungal meningitis. Now, if there is tubercular meningitis, then you should send the culture and you should do the PCR, and you should start the right treatment. You should start the anti-tubercular treatment, that is RIPE, that is rifampicin, isoniazid, pyrazinamide, and ethambutol. You should start it and you should give it for the 12 months. Now, it is very important. In case of tubercular meningitis, you have to give the anti-tubercular therapy for the 12 months. But in case of pulmonary tuberculosis, you should give the anti-tubercular treatment for the 6 months. So it's important. Along with that, you should give on the steroids. Steroids is very important because these steroids, it will prevent the most common complications, deafness in the patient. Now, in case of viral meningitis, you have to give the ceftriaxone to the patient. Now, in fungal meningitis, you have to see for the cryptococcal antigen, right? So, as the fungal meningitis is most commonly, it is caused by Cryptococcus neoformans. It is most common in immunocompromised patient and HIV patient. And the drug of choice for the fungal meningitis, that is, yes, that is amphotericin B. So in the treatment, first you should send the sample and start empirical treatment. So and that you have to give the ceftriaxone with the dose of 2 gram IV BD along with vancomycin with the dose of 15 to 20 mg per kg, right? It is given IV BD. So if the patient age it is more than 50 years or the patient is alcoholic, so in that condition you have to give the ampicillin with the dose of 2 gram, right? It's important. But if the patient is resistant, if the patient is resistant to beta-lactam, so in that condition you have to give ciprofloxacin in place of this ceftriaxone, and you can replace the ampicillin with the trimethoprim sulfamethoxazole. So, and you have to add the dexamethasone. Dexamethasone is very important, more specifically if the patient is infected with meningitis that is caused by Streptococcus pneumoniae. So it is very effective because it prevents the most common complication of meningitis. You know what is the most common complication of meningitis? That is deafness. Now, if the patient is immunocompromised, so in immunocompromised patient you have to give ampicillin with vancomycin and with the ceftazidime, which is third generation cephalosporin with the dose of 2 gram. Now if there is head trauma, so in head trauma you have to give vancomycin with the ceftazidime with the dose of 2 gram IV, right? Now in prophylaxis, what you have to give people who comes in contact with meningitis patient, so in that condition you have to give the rifampicin with the dose of 600 mg BD per orally with 2 days, or you can give the ciprofloxacin with the dose of 500 mg per orally, or the another option is ceftriaxone with the dose of 250 mg IM, right? So this is how you can treat the meningitis.